With that, I want to introduce our first speaker, and that's Dr. Richard Dutton. Now, when I knew Rick Dutton, he was the director of trauma anesthesiology at the Shock Trauma Center. And Rick just impressed me consistently throughout the year, both for his brilliance, but I think even more importantly was his demeanor. No matter how bad things were, no matter how many sick patients you got at once, no matter how much guff you were getting from other services, Rich never got upset. I never once saw him over the course of the year raise his voice. Last night he said it happened a few times behind closed doors, but we never saw it. All we saw is this calm, collected, incredible clinician taking care of patients. And for that, I just looked up to him as a mentor throughout that year. Now, just as background, Richard Dutton did his undergrad at Harvard and then went on to medical school at Tufts. He did an anesthesia residency at the Mass General, and then gave service to the military at the Bethesda Hospital as their lieutenant commander of their anesthesia department. And then he came to shock trauma, and he pretty much stuck there up until recently, moving up through the ranks until he eventually became director of anesthesia, director of quality, director of operations, and then he defected to what I look at as a desk job. But it's an incredibly important desk job. He is now the director of the Anesthesia Quality Institute. So he's going all across the country through the auspices of the American Society of Anesthesiology, and he's trying to make patient care safe. So if you ever have to go through an operation, Rick Dutton is trying to make that as safe as possible. Maybe we'll hear a couple of things about that, but primarily what Rick's going to be talking about is the resuscitation of the sick trauma patient. So with that, can I please have a round of applause for Richard Dutton?
Thank you. Well, thank you very much, Scott. I'm sorry my mom isn't here. She would have liked that. Let's see here. Get this fired up. I got it. Okay, off we go. All right, good. So, Scott told you my day job now is manufacturing quality for the anesthesia world. That's keeping me fairly busy, and I get to do a lot of travel. But my night job remains trauma care. I still do that several nights a month back in Baltimore, and it's still really my first love, and my academic interest is in dying people. I assume many of you it's the same, and that's what we're going to talk about today. So this is the fancy technical term, what we call hemostatic resuscitation. This is the new wave thinking about resuscitating bleeding trauma patients, and that's where we're going to go. There's a whole bunch of drugs and devices and so forth scattered throughout this. I have, over the course of the last 15 years, worked with most of these companies at one time or another, consulting with them, designing studies, doing research for them, etc. I don't have any financial interest in any of them, and I'm not really here to sell anything. Here we are. This is the big white box of chaos in downtown Baltimore. If you just to orient you on this picture, so this is the R. Adams Cowley Shock Trauma Center. It is a specialty-built freestanding trauma hospital. 100 patient beds in here, of which slightly more than half are critical care beds. There's some step down and a little bit of med-surg stuff. The second floor here, where there are no windows, is 13 admission bays, trauma resuscitation bays, 2 CT scanners, an angio suite, 6 operating rooms, and a recovery room. And that loop around the second floor is the hamster wheel that I spend most of my nights there running around. It is, this building is unique, and this system is unique in many ways. Probably the most important of them is the way that Dr. Cowley, when he built this, embedded this in a statewide system. And creating this building is not that hard, really. And creating a single trauma service that works to the best of your ability to make one is not that hard. But building a state system to support it is the real trick, and that's what really makes Maryland unique. So you see the helicopter at the top with the Maryland state colors on it. That's because the helicopters in Maryland are flown by the state police. If you're injured in an auto accident on I-95 in Maryland, the helicopter swoops down from the sky and picks you up and takes you to the trauma center, and that is a public service. So that's free. You don't get a bill for that. It's paid for by the taxpayers of Maryland. And that sort of embedding of trauma in the public consciousness as a public service with a statewide system of triage and transport is what really makes Maryland work. So that's sort of cool. The rest of the brick stuff in the background here is the University of Maryland Medical Center, a traditional, very typical academic hospital. If you go about 3 blocks this way, you're in the Inner Harbor, which is the beautiful posh area of downtown Baltimore. Back toward the camera or the stadiums where the Orioles and the Ravens play, also getting to be a nice area. To the north and west of this picture is the beautiful neighborhood where they filmed The Wire and Homicide, which is why it's a good place for a trauma center. This is the busiest trauma center in the United States. We get about 6,500 to 7,000 direct admissions from the scene of injury. You can't walk into this trauma center. You have to be brought by a medic, either by ground or air, following the state triage protocols. And we get another 1,000 or now up to about 1,500 transfers from other hospitals. And those can be both trauma patients and other sick surgical patients. So let's organize our thinking here with a case. This is PJ. He's a real patient, one of my favorites. He's somewhat topical since he has a wintertime injury. And unlike what Scott said, this is not a bad person. This is your basic Mark I trauma knucklehead. And you can see he went out and had a few beers with his buddies and decided to go sledding one night during an ice storm at midnight, which might have made it hard for him to see the tree that he slid into at a high rate of speed. He was impaled on a tree branch. He kind of busted himself free from that, staggered back to his house, collapsed on the front porch, fortunately making a loud enough noise that his parents heard the thump. They opened the door. They found him lying there. They called 911. And we got our first call at the trauma center at about 1 in the morning, which was, sledding accident by air 15 minutes. And we had a nice chuckle about that. And then 5 minutes later, the flight medic calls back, and he says, basically, this guy looks somewhat sick. And he gave us the vital signs, which you can see, and said, he seems to have an expanding abdomen. And all he could figure out about the injury was that there was some sort of penetrating injury in the perineum. So this is what we got. And here we are. This is the trauma team descending on a patient. This is not PJ, but a typical patient at the trauma center. And this team is a little bit unique in the United States now. It is led by an attending trauma surgeon who is sitting somewhere in the vicinity. Organized and managed by a trauma critical care fellow. Scott's been one of those. Sean, who's in the audience, has been one of those. Maybe there's others. Who could be a surgeon, emergency medicine person. There are a bunch of residents, there are a bunch of medical students, there's a bunch of nurses and technicians and other trainees. There is an attending anesthesiologist, typically standing about where the camera is. And I am, when I'm there, when I'm that person, responsible directly for the airway management of the patient and contributing to the resuscitative management and the general flow. I think this is the only trauma center ED in the country right now where an anesthesiologist, an attending anesthesiologist, really physically attends every trauma admission. There are a bunch of places that have triage systems or specific calls where they invite anesthesia. And as you well know, there are a lot of places now where the anesthesiologist is hiding in the OR and couldn't find the emergency department if they had to. I have trained, typically working for me as an emergency medicine resident. We get all the residents from Hopkins and all the residents from Maryland. It's about 35 a year between the two programs. They all rotate through the trauma center. They spend a couple months on the trauma team, so on the side of the bed here, managing patients directly, and they spend 1 month with the anesthesia department doing airway management. It's a really fabulous way to learn airway skills. Each of those residents gets between 50 and the record is 98 intubations in their month with us. Between the OR and the trauma center, and many of those are in this nice emergency setting, so it's a nice setup for them. So if we're going to save PJ's life, and he's obviously dying of hemorrhagic shock or wouldn't be talking about him, he needs to get to the right place quickly. He needs his airway and breathing management taken care of just to get that off the table. We need to figure out what's bleeding. We need to achieve anatomic control of hemorrhage, because really without that he's not going to get better. And we need to get him resuscitated. So this is all motherhood and apple pie stuff. Off we go. We'll get him intubated, and Scott's going to talk about this later, so I'm not going to get into the details. Suffice it to say that this is a rapid sequence intubation at the trauma center. We do on the order of 1,000 of these on an emergent basis a year, so within the first hour of patient admission, and another 5,000 or 6,000 in the operating room within the first 24 hours of admission. So the whole full stomach cricoid pressure, inline stabilization stuff is just kind of routine there for everything we do. And I won't go into more details than that. This is what PJ happened to get: a homeopathic dose of pentothal, a serious dose of succinylcholine. Now, of course, neither one of those are available in clinical practice today, but 4 or 5 years ago we had them, and hopefully will again, because I really do think those are the best. He got intubated. He had bilateral breath sounds, positive end-tidal CO2, which is instantaneous in our center based on how we're set up, and no blood pressure. So this is the typical Pensuck CPR induction, and off we go. He needs circulation managed. So it turns out that PJ's last conscious act as he came off the helicopter was to remove his only IV. He was kind of thrashing around. So he hit the bed in front of us. He didn't have one. He looked pale and gray. He needed to be intubated. The team started a right femoral venous introducer as the quickest thing they could do. That's where he got his pentothal and sucks. He fasciculated. We intubated him. He had no blood pressure. As that line went in, 30 cc's of blood went off to the blood bank and to the lab, and you can see what was done. And then we hooked it to some running fluids. And interestingly, the fluid that went in him, he got exactly 0 crystalloid. He got a unit of type O uncross-matched red cells and a unit of pre-thawed type AB plasma. So emergency release or instant use red cells and plasma, 1 bag of each on that spiked set into his femoral line. And that was his initial fluid in the trauma center. 1 dose of epinephrine. Everybody responds to epinephrine once. CPR for about 30 seconds. And he had a visibly distended abdomen. Somewhere in here we had a fast that was very positive. And off he goes to the OR. And his time in the trauma bay was truly about 10 minutes. Now, we talk about this all the time, about how quickly we can get to the OR. At the Shock Trauma Center, this is real, and I can prove it because we videotape all this stuff, so we actually do periodic look-backs and can count. And PJ really was about 10 minutes getting all this done and off to the OR. The OR is about 10 feet away down the hall. It's through 1 door. And here we are in the operating room with a lot of stuff to manage major hemorrhage. So you can see a cell salvage system here. We hook that up to everybody. We don't always give the blood back. It depends on what's injured and if it's contaminated and so on, but we have it. This is the rapid infusion system, the Cadillac of rapid infusion devices, and I'll talk more about that later. You can see a hotline here in the background, but the most important piece of equipment for PJ is standing in the middle of the room here. This is Dr. Militello. He's a trauma surgeon. And the first thing I will say about saving PJ's life is, more than anything else, he needs the surgeon operating on him. If you can't fix the anatomy, nothing else matters. So it's unfortunate that this is so, because we all hate surgeons so much. But the cold hard truth is that you and I are in a service industry, and our best way to save PJ's life is to get him in front of the surgeon as quickly as possible. And I'll talk about a couple of notable examples where that didn't happen but this is one of the things I try very hard to get my own faculty over. It's not about us, it's about the patient. And the most important resuscitative thing we can do with a patient in hemorrhagic shock is get them to the operating room and control the anatomy. So everything else I say starts from that basis, and in fact, that's what we did with PJ. So we got an A-line in a couple minutes after we got to the OR. Nowadays, we would use ultrasound. There are just a certain number of blind sticks. You didn't really have much of a palpable radial pulse. But we do get a line in, and we send labs. And here he is. Looks great, huh? Right, so PJ has some issues at this moment. And the issues are not exactly what you might expect. I mean, the pH and the lactate, okay, that's pretty clear. Interestingly, even though we're ventilating him and doing just fine, almost every patient who has these will have this, at least when you look at their first gas. The fact is there's just a lot of CO2 to wash out, and this doesn't mean you're ventilating the person poorly. In fact, you're probably doing fine, it's just you're way behind. And that's pretty common. We see that a lot, and we don't worry about that. You'll notice this hematocrit's actually kind of okay. Why? Because we've given him blood, and that's all we've given him. And then this number. This is a good way to win bar bets in the emergency department literature, because it turns out if you ask the question, which single laboratory value that you can measure in the TRU correlates best with patient outcome after trauma, so live, die, one lab value, the answer is the INR. And you can do it by PT, but if you're sexy, it's the INR. And the reason is that it encapsulates the two reasons that trauma patients die, which is brain injury. And severe brain injury, you release a lot of tissue thromboplastin, you take out all your factor VII, and your INR goes up, and hemorrhage. And obviously, hemorrhage and coagulopathy lead directly to death as well. So here's data from our trauma center over about a 10-year period, and the N isn't, 5-year period. The N isn't on this, but it is 36,000 cases. So this is 36,000 trauma admissions, and this is their admission INR, all right, and that's the bins here. Okay, so less than normal, kind of high normal, and then levels of elevation. And this is their injury severity score, and this is their mortality. And you can see in the severely injured patients, so PJ is a 25, he has severe single system injury, you can see a very nice stair-step pattern. And in fact, the correlation between INR and mortality has got like 18 zeros after the P. So this is it. Very interestingly, for those of you who are contemplating academic careers, if you look down here at the bottom two bins, so 0.8 to 1 and 1 to 1.2, that's normal range INR. But you'll notice in this very large sample that if your INR is high normal compared to low normal, your mortality is twice as high. We have no idea what that means. I'm fascinated by that, and I think that would make a great research project someday for somebody, because we don't know if this is certain patients who are just walking around with a genetic predisposition to bleed to death, in other words, you walking around with that high INR, or whether this is subtle evidence of injury and bleeding and trauma. And sorting that out would be a fascinating question. All right. As we drag PJ into the OR, here's what we're thinking of. Expediting control of hemorrhage, I said that, I won't say it again. No crystalloid. Crystalloid does nothing good for a trauma patient. Keep the blood pressure low. Give blood products early and often, 1 to 1 to 1. This is very sexy, lots of talk in the literature. It's wonderfully controversial, so people keep publishing about it, pro and con. Yeah, I made that up. I made that up as a simple algorithm in about year 2000 and put it out there for my guys and then eventually for the military who we were training at the time. And there it is. And I'll explain where that comes from and why I think it's good and why I think it's bad in a second. Frequent labs, there are certain things you have to stay on top of. The lactate is kind of your scorecard, so it tells you how you're doing. The ionized calcium is something you have to actually manage. That is, if you get more than about 6 units of red cells or plasma in an hour, your calcium starts to go down because you're getting citrate intoxication, and you have to treat that by giving calcium. So you have to pay attention. And then this concept about deep anesthesia, this is where I go off the end of the evidence base into physiologic thinking and sort of theory, and I'll talk a little about this at the end and why I think this is important. All right, fluids. We know that fluids are bad for trauma patients, bleeding trauma patients. We've known this for a long time. So this is a great paper if you're into history. Walter Cannon was a surgeon in the First World War, and this paper, which was published in JAMA right after World War I, describes intravenous fluid therapy. This is the birth of IV therapy, and he explains how to mix up a bag of fluid and how to connect tubing and how to grind the bevels on a needle to put them into a vein. And this is it. This is IV fluid at its birth. And you'll notice that right from the start, they knew that if you gave fluids to bleeding people, it made them bleed more. It's a pretty simple concept. Right? Here's the very simple graphic of that. You have all witnessed this in the emergency department. ATLS now refers to these people as transient responders, meaning you give them a bunch of fluid, they get better, then they get worse again. Why? Because they're continuing to bleed, or because you made them re-bleed. Right, by giving them the fluid in the first place. This is what's going on. So in the 90s, people kind of caught on to this, actually in the 80s and 90s, and there's a lot of literature about it. Here's the classic pig model. This is published about early 90s by Susan Stern at Michigan. And you rip a hole in a pig's aorta, you get an uncontrolled hemorrhage, you can resuscitate the pig to different blood pressures, and here's what happens. If you try and make them normal, they mostly die. If you don't give them any fluid at all, they mostly survive. And if you actually measure oxygen delivery, you discover that you get the best delivery, and these 11% and 22% are equivalent survival statistically if you give them a little fluid but not too much and keep their blood pressure down. That's pigs. We have rats. A very elegant rat model from the University of Pittsburgh. Multiple phases where they chop the rat's tail off, which causes this uncontrolled hemorrhage, and then you watch them bleed for a while, simulating pre-hospital care, and then you put a Band-Aid on it, simulating first aid, and then you get a little crystalloid simulating transport, and then it gets to the rat OR, and so on. And so a very elegant pig or a rat model, and again, different groups manage to different target blood pressures. And depending on how much of the rat's tail you cut off, you can get a very lethal model. And this particular model is 100% fatal if you don't do anything. So no resuscitation, they all die. If you don't give them any fluids up front, they mostly die. If you give them a little bit of fluid but keep their blood pressure low, they all survive longer, and some of them survive permanently. But if you try and make their blood pressure normal, they all die again. All right, and they have the most blood loss, not surprisingly. Sheep. Sheep are fuzzier, so this is for those who like fluffy animals. The sheep were not killed. This is a non-fatal sheep model. This is pulmonary vein hemorrhage. You arrange a hole in the pulmonary vein, and you simply stick a chest tube in and see what comes out. And this is a very simple model, and they did it under two conditions, either giving fluid or not giving fluid. And here are the results. If you give fluid, you lose twice as much blood, you bleed for twice as long, and here's the quote from the authors about that. Now, I had, in selecting what I put in my talk, I have hundreds of these studies, because this has been repeated endlessly in animal models, even to the present day. People are still doing this kind of work and still finding the same results. So I had a lot to choose from. Why did I pick sheep? Anybody know who died of this injury? Very notably? Pulmonary vein hemorrhage? Princess Diana. So Princess Diana bled to death at the side of a French highway, getting serially resuscitated for an hour or more from a pulmonary vein hemorrhage that was probably very surgically treatable had she been in an OR, which she wasn't. All right, so she's a living example of why stay and play is not in favor right now in trauma care. All right, scoop and run, get the patient to the OR, and then this concept of deliberate hypotension comes into play. All right, if you want to read it all in one place, here it all is in one paper. It was a supplement to Critical Care Medicine in 1994, and it summarizes hundreds of animal papers, all coming to basically the same conclusion. Less is better. All right, people. Houston, the Maddox trial, so-called. He was the senior author. He was a particularly warped trauma surgeon in the city of Houston. He ran the pre-hospital care there. And in Houston in the early 90s, if you were shot, which was quite likely because they were having a cocaine war at the time, and you had penetrating thoracoabdominal trauma, the medics rolled up. If you were hypotensive, you got put in the study. And if it was an odd day of the week, they started your IV and gave you fluids. And if it was an even day of the week, they started your IV and HEP-locked it and took you to the hospital. And you stayed in that state, either fluid or no fluid, into the operating room, so through the ED, into the OR, at which point you got standard of care. They documented that the two groups had a 2-liter difference in the amount of fluid they'd gotten at the moment of OR arrival, and they documented a survival benefit in the group that got no fluid. And this is statistically significant. This was published in the New England Journal of Medicine. This was a landmark paper. You should all read it. There were some problems with the study, not surprisingly. It was only penetrating trauma, so big question, what about blunt trauma, which even in beautiful Baltimore, blunt trauma is 80% of the business. Pre-OR only, and this is my biggest objection to this as an anesthesiologist and a physiologist, is that the anesthesiologists in Houston were not on board with this study. And if you've met Dr. Maddox, you might understand why. And what they actually did is they hung a really big bag of fluid below the level of the drapes where he couldn't see it and yell at them. And every patient who came in, they just cranked that in first thing. because as an anesthesiologist in 1992, I can tell you volume, volume, volume. That's what we were taught, that's what we thought, and anything else was considered heretical. So if the anesthesia department had actually been on board and preserved this fluid restriction until the patient had actually stopped bleeding, like the spleen was out or whatever, they probably would have had even more dramatic results. They did their best to sabotage it here. And then lots of commentary about the approach. This is all or none, but clearly in the animal models, you want to be in the middle. And then a whole bunch of wrangling about which particular patients survive. Now, this is all sort of post hoc useless, because when the guy hits the bed in front of you in the ED, you have no idea what's injured. So trying to restrict it to certain groups of patients doesn't make a whole lot of sense. We picked up on that and looked at it ourselves. So I had a fellow from England at the time, Pete Hambley, and he said, oh, let's take a look at this. So we pulled up every case who'd gotten the rapid infuser hooked to them over the previous couple of years. And we looked at their actual survival, their predicted survival based on their injuries, and then we tried to find a control group that had not gotten fluid through the rapid infuser. And what we discovered is that attaching the patient to the rapid infuser lowered their survival by about 10%. And if you looked at it in a case control way, you had about a 5 times greater chance of dying if you got fluids through the rapid infuser. Now, this is retrospective study, and there's a huge amount of bias in this. Obviously, we picked sicker patients to connect the risk to, because there wasn't any protocol for it. So this only gets you so far. So we went on after that to look at it in a prospective randomized way. And in the latter part of the 90s, if you rolled into the trauma center and you were bleeding and you were hypotensive, we ripped open an envelope and randomized you to, we said, normal blood pressure management, so systolic in 3 digits, that classic 3-digit blood pressure that warms all our hearts, versus trying to keep the systolic pressure at about 80. And it's first thing we discovered is that's really, really hard to do. You really have to restrain yourself, and to the point of fist fights at some points between me and the nurses and the residents and so on, to not give that patient fluid if their blood pressure is 85/40. Because 85/40 is perfect. You don't need to do anything, but it's really hard to convince yourself of that, and the nurses of that. But we did it. We got everybody in the center on board. We took all comers, as long as they weren't too old and not badly head injured. And you can see we did this. And we tried, unlike the Maddox thing, we tried to continue that therapy or that approach until we were pretty certain they had stopped bleeding. No difference. So here's the result. Well, first of all, we did achieve a difference in blood pressure. One of the things we discovered is if you don't give fluid, the blood pressure recovers anyway, because they stop bleeding, they auto-resuscitate, and their pressure will spontaneously rise. And we saw that in a number of patients. And that's one of the characteristics of this, is that we could really tell physiologically when the patient had stopped bleeding, because they stopped needing fluid. It's sort of interesting. All right, 4 patients died in each group. There's a bunch of statistical wrangling. You'll notice that our overall mortality in this cohort was way less than what it was in the Maddox trial, where the overall mortality was 35%. Here it's 8%. So that's some selection differences. That's some system differences. That was interesting. And there was a big Hawthorn effect with this, which is because we were watching every drop of fluid as it went in, probably even the people in the high group were getting much less fluid than if we weren't paying attention. All right. But the interesting effect of this study, even though we stopped it and wrote it up as no effect, it changed practice completely. It changed practice in our trauma center. Everybody said this is clearly better. I mean, everybody who had their hands on it, it felt better, it looked better, and it changed what we did. And that's pretty much been the standard of care in the industry in level 1 trauma centers since then, is try and keep the blood pressure low. Now, on to the composition side. So what do we give, or what should we give? So part of my thinking about this at the time was, well, giving a lot of fluid is clearly bad, but maybe that's just because we're giving the wrong fluid and we're diluting the patient. And maybe if we gave the right fluid, the blood pressure wouldn't matter as much. So we started thinking about the right fluid, and this, as I say, came from about year 2000. And this is a thought exercise that my blood banker and I went through at about that time. In year 2000, I got a new blood banker, a guy named John Hess, who worked with the Army for many, many years on blood research and transfusion issues. And he and I sat down and started looking at our data. And here's one of the exercises that we ran through. You donate a unit of blood to the Red Cross. They get 500 mLs of nice, happy, whole blood, and you can see it all has normal values here. They add a bunch of fluid to it. They spin it. You get it into 3 bags, and the bags all look kind of okay. If you mix those 3 bags back together in your rapid infusion system, for example, and then you send labs on the fluid at the other end, this is what the patient's actually getting. They're getting something with a hematocrit of about 29%, about 88,000 platelets, and about 65% clotting factor activity. So the take-home point from this thought exercise is, if we give the patient nothing but blood products in exactly even proportions, we end up at the end of the day with blood that is barely compatible with life. So this changed our thinking quite a bit, in that we stopped giving crystalloid absolutely, because clearly that's not helping at all, and we went to this 1-to-1-to-1 mix for patients that were really at risk of dying. All right. This led to some further thinking about it, and you can see Dr. Hess's name on this. And this came from a group, an international group actually, of thinkers about coagulation and trauma. And this was on the cover of the Journal of Trauma a couple years ago. And this is our current thinking about coagulation and trauma. And the traditional stuff is in here. So you resuscitate, they get diluted, they get cold, they get coagulopathic. They're in shock, they get acidotic. That makes them coagulopathic. So all that sort of traditional bloody vicious cycle stuff is in here. But what's also in our current thinking about it, first of all, underlying conditions, and the aspirin Plavix kind of stuff that we see more and more of, but also over here this concept of ACOTS, or acute coagulopathy of traumatic shock. And this was the recognition and the realization that shock by itself makes you coagulopathic. This is largely the work of Karim Brohi in London, and he did the work at San Francisco General. And what he basically found is that without a drop of fluid, trauma patients are coagulopathic at the time they arrive at the hospital. And you saw that in our INR data as well, and he has a similar slide. What's going on as he took apart the physiologic mechanism is that ischemic cells release lots of factors, signaling agents and direct toxins, that are themselves anticoagulant. The particular one he focused on was protein C. An ischemic cell releases protein C, which is fibrinolytic, right, and so contributes to the coagulopathy. And this scientific recognition, or understanding the biochemistry of this, again, contributed to our thinking that we should be doing more to support coagulation early on in trauma patients. So here's our current theory. Any fluid which doesn't clot or carry oxygen should be suspect and should be avoided. We give a lot of type O uncross-matched blood in the trauma center, about 600 units a year in our practice to about 200 patients. Their outcomes after that are exactly consistent with what would be predicted, about 35% death. We have in now 20 years of giving uncross-matched type O blood, we have never documented a transfusion reaction from it. And interestingly, if you really dig into the blood banking, the biochemistry of it, very few patients react to it. Very few patients seroconvert, even if they're Rh negative and you're giving them O positive blood. So we use O positive because it's cheap and plentiful. And we've never had any problem from that. In theory, if you give O positive blood to a negative patient and they survive, you should treat them like you would a pregnant lady with an Rh positive baby and treat them with Rogam and so on in the long run. But I'm telling you, it's probably not even necessary because very few of them actually make the antibodies in the face of hemorrhagic shock. You don't have to take my word for it. This is the Vietnam War experience. The Army gave 700,000 units of blood during the war. 600,000 of those were cross-matched units. In that 600,000 experience, they killed 7 people. Private Smith got Private Jones's blood, bang, dead. All right? And they gave 100,000 units of uncross-matched type O blood, and as far as they can tell, they didn't kill anybody with that. If you held a gun to your blood banker's head, or got him really drunk, you can get them to admit that if we had enough type O blood, we wouldn't bother with cross-matching. We'd just give O to everybody. Right? The problem is we don't, and that's why we do cross-match blood. It's to match a narrow supply to a big demand. We started giving plasma early, and you saw PJ as the index case. He's one of our earliest patients who got the instant use of pre-thawed AB plasma, universal donor plasma. AB plasma is rare, it's hard to get, and this requires a lot of logistics to put in your trauma center and support. We do it by issuing the AB to the trauma bay, basically to our refrigerator in the trauma center. If it's not given within a couple of days, it cycles back to the blood bank and they reissue it to somebody who needs plasma. So we don't waste any, but it still requires a bunch of tap dancing to get this done. This was the Army's experience with 1-to-1. You've probably seen this slide. This was also a Journal of Trauma cover shot. And this looks at their experience. So they got the 1-to-1 concept from us. Colonel Holcomb had been chatting with me about this. How do we do it? We trained a lot of their residents. They took this to Iraq, and this is 252 massively transfused trauma patients in downtown Baghdad, U.S. soldiers. So this is all Iraq war activity. By massively transfused, they all got at least 10 units of red cells within 24 hours in the hospital. And this is their mortality, so their outcome based on how much plasma they got with the red cells. And the ratios are a little hard to interpret, but what it boils down to is if you got about 1-to-1, so about a unit of plasma for every unit of red cells, your survival was good. And if you got 1-to-8 or lower, your survival was bad. All right? This caused a huge stir in the military. When they published this, they changed their policy. It basically became the rule in Iraq and then Afghanistan. If the patient's in hemorrhagic shock, they shall get 1-to-1 resuscitation with red cells and plasma. They worked on their logistic chain so they could get plasma to the bedside quickly. And their subsequent data from various publications from the war, they've gotten much better outcomes. This was, again, on the cover of the New York Times a couple weeks ago. Outcomes from the war much better. And truly, the killed in action statistics from Afghanistan are better than they've been in any major conflict in the U.S.'s history. This is one of the reasons why. Now, that said, for the residents here and the budding academics, this is a tremendous example of lying with statistics. So, right idea, I strongly support the principle. This data is bullshit, though. Why? Well, think about it. This is retrospective study, who got the plasma? The patients who were bleeding slow enough for the plasma to arrive at their bedside and get transfused are the ones that got the plasma. If you were bleeding really fast, you got the red cells first and you died before you got the plasma. So if you actually take the survival bias out of this data, it's a lot less impressive, but nonetheless real. I mean, it is a real effect. It's just harder to prove than the Army thought. All right, so the concept of hemostatic resuscitation. Act prior to the onset of coagulopathy, so right from the first if you think the patient's critically injured. Try and maintain the INR normal. Plasma platelets equal proportions to red cells. That's how we start every resuscitation at the trauma center now, and that's what I would recommend. Here's PJ. He gets the OR. We do an emergency XLAP. He is bleeding from, fortunately, a single point. He had the stick that impaled him had gone through his right iliac vein. That was an easy surgical problem to fix. You don't need that. They just ligated it and ligated the distal branches to stop the back bleeding. This is true damage control surgery, so they stapled off the hole in his colon, just bang, bang, did not try and reconstruct it. Pack his abdomen, sterile dressing over the top, so open abdomen coming out of the OR to the ICU. Let's get him resuscitated. This is what we were doing on our side of the drape. Warmed room, paralysis so the surgeons can work. Right subclavian venous introducer, if you were following along, there's probably a couple of you who are awake and realize we put a femoral vein line in below his iliac vein injury. I mentioned that the succinylcholine did work, so something good happened, but probably that wasn't the place to continue resuscitating him through. So we got a line above the diaphragm, we got his A-line in, blood and plasma 1-to-1, starting with the uncross-matched or universal donor stuff. And then this concept of anesthesia. And as I say, I have no evidence for what I am about to say. So there's no science behind this. This is just physiologic theory. But my further thinking about this process is, why can't we have our cake and eat it too? In other words, we need to keep them hypotensive to help the surgeons with the mechanical process of making them stop bleeding. Right? If we raise the blood pressure, we wash off clots, we bleed more, right? But keeping their blood pressure low, we have traditionally done by fluid restriction, but why do it that way? Why not try and resuscitate the person at the same time? So in the new millennium, with very good control over inflow and outflow and good monitoring and lots of help in a good center, this is how we actually do it. We try and get them anesthetized at the same time. So we take away their vasoconstriction take away their hypoperfusion as we go. And the way we do this is we bring them in the OR, we get the A-line in, we look at the blood pressure, and it's 60/40. We say that's lower than we like, so we give them a bolus of fluid. We give them a dose of fluids, and we do it in a very controlled way. And we actually give it 100 ml bolus, so tiny. All right? But we push that in. The patient's very vasoconstricted at that moment. They're a very tight ship, and a little bit of fluid goes a long way. So we look at the blood pressure, and it goes up to, say, 90/70. Great. All right? But that's higher than we want. So at that point, we give them a little bit of anesthesia. I personally use fentanyl. Again, no data about what's right, but I'm a cheapskate, and fentanyl's cheap. So we give them a very little bit of fentanyl. That takes away some of their catechol drive, and sure enough, their next pressure's lower. And then we give them a little fluid, and then we give them a little fentanyl, and we give them a little fluid, and a little fentanyl. And we do that back and forth on a sort of minute-by-minute basis, titrating two things. We are trying to expand their vascular space by taking away their catecholamines, reversing their vasoconstriction, so we're trying to perfuse the patient without ever letting their blood pressure go up. And this is how we do it. So we open their vascular space with anesthesia, we fill that space with fluid, so we're not fluid restricting the patient, we're just not overloading them, and we're doing it in a very controlled way, all right, while keeping the blood pressure down so the surgeons can make them stop bleeding. And this is, in fact, what we do with patients like PJ, and about once a week in the trauma center, we fall into this model. It would be exactly the same for you in the ED, resuscitating that patient with pelvic trauma that you're managing as they get through CT and angio and so forth. You do want to anesthetize the patients. Anesthesia is really good for people physiologically. It vasodilates them. It greatly improves survival if you look at bleeding data. But has anybody studied this in trauma patients? No. All right, so here's PJ about an hour or so into it. The surgeons are done. They've packed him. There's nothing anatomic bleeding. He is still very coagulopathic. You can see we're still in the hypotensive. And it's not unusual for patients who get a lot of resuscitation at some point to become unresponsive. So we give that 100 of fluid, nothing happens. That's a bad sign. It either means they are freely bleeding, which in this case was not the case because we could see, all right, or that something else is wrong. And the something else is often calcium, so you get a blast of calcium at that point, and that often fixes their citrate intoxication. They get better, all right? He is still coagulopathic, he is still acidotic, and that's probably contributing to his woes. He had a very, very, very big dose of shock up front. Depth and time, the integral of that, your dose of shock, he had a lot of it, and that's some of what's impairing him here. He was right on the border between surviving and not surviving at this point. Now the problem is here, it's very hard to fix this giving plasma, because plasma is very dilute. So it's easy to keep up with the one-to-one. It's very hard to catch up. And what he needs is some way to rapidly make him stop bleeding. So if we could define that, here are the characteristics of the ideal hemostatic agent. It'd be easy to use. It would stop bleeding but not stop arteries. Right? You can give thrombin, IV. It works great. People stop bleeding instantly, completely. You know, carotids, coronaries, that all just stopped. That was discovered in the 30s. Not a great moment in medical history. Anyway, we need something that works very specifically at the site of injury. And of course, in 2010, it's not allowed to have any side effects. And if we could make it, it would be free. So this is what we had, or the first thing that we had that was like this. This is factor 7. It does not meet all of those characteristics for this reason. This is a PJ-sized dose of it, about 100 mics per kilo. This is 8.4 milligrams of factor 7 in the picture. And this has an acquisition cost to your hospital of about $7,000. So this is an expensive maneuver. But it does have some of the characteristics we're looking for. So I promise this is the only slide like this in here. You tear a hole in a blood vessel. You expose tissue factor on the injured endothelium. Your activated factor 7 in your circulation sees that. This is the canary in the coal mine that tells your body we need a clot here. All right, it reacts with tissue factor. That complex reacts with, makes a little bit of thrombin, which activates the platelets, blah, 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 blah. You get a thrombin burst right there in a clot. And I won't go through that, but there are very good resources out there if you want to look at what we now call cell-based coagulation. This is why factor 7 works and why it's specific. The clinical effect of giving factor VII is that your prothrombin time drops like a stone. This is the first 50 people we gave it to in the shock trauma center. Prothrombin time before, prothrombin time after. You can see the general effect here. And I should point out that these are all of 10 minutes apart. So this is a very good drug for anesthesiologists and emergency medicine physicians and other people with very short attention span and a strong desire for immediate gratification. This works right away. TEG, same story. If you're into TEGs, we might talk about that later. Here's how it works functionally in the trauma center. Because it's expensive, our hospital has put rules around this. We helped create the rules to make sure they worked the way we wanted them to. This is how it goes. Any physician can request off-label factor VII use. It has to go to a gatekeeper. For many years, that was Dr. Scalea and myself. It's now Dr. Scalea, Dr. Stein there. And what they are interested in is the patient bleeding to death? Are they coagulopathic? Have we tried and failed with the conventional approach, whatever that should be for that patient? And most important, if we get them to stop bleeding, are they going to survive? So patients with very severe brain injury, no. Patients who have a fatal dose of shock already, no. And sorting those out is the hardest part of doing this. And because we were running it through the gatekeeper, we got to keep track of who got it and follow the data. We're well north of 500 patients at this point for a number of indications. You can see here, interestingly, as we've gotten better at this whole one-to-one and hemostatic resuscitation, we use it much, much less for these patients because we don't have to. All right? It is still a great drug for patients who are coagulopathic with TBI. If I fall and have a subdural and my INR is 2 and the neurosurgeon comes by and say, he needs his subdural evacuated, but you need to get his INR to 1.3 before we'll take him to the OR, I want factor VII at that moment, and I want to go to the OR right now. And that's how we've done it at the trauma center for the last 5 years. It works great. You save a lot of lives that way. And that's a fundamental clinical statement, but I actually have data if you want it. We used 2 different doses because we discovered over time that you didn't need the big blast in everybody. So somebody like PJ, who is already very diluted and actively bleeding, gets what we call the big dose. This is the hemophilia dose, 100 mics per kilo. That's the expensive one. But everybody else, so if I have my subdural and high INR and I want a dose of factor VII, you want the smallest possible dose. It's now 1 milligram in the small vial. And that's all we give. It's about 10 mics per kilo, depending on your population. And it does just as well. It does everything the big dose does. It is still a pharmacologic dose. It still gives you about 10 times the normal circulating active factor VII level. So it works fine. And for all of our TBI patients, that's what they get. And we have very good results with that. Dr. Stein's published now 2 or 3 papers of that series that you can look at. Pretty much 90% of the people you give it to will stop bleeding. The 10% who don't, it's because they have a very deep dose of shock. Now, Tannstoffel, I don't know if there's any science fiction fans in the audience. This is from Robert Heinlein. It's not a Dutch word. It actually is an acronym, and it stands for there ain't no such thing as a free lunch. So here's the free lunch part of factor VII. It is a very potent prothrombotic agent. It causes clots. Guess what the complication is? All right. And from our series, this was at about 300 patients, another former fellow. About 9% of all the patients we give factor VII to go on to have a thrombotic complication. That's incidentally slightly lower than the rate for badly injured trauma patients. All sorts of different things happen. About 3% of those we think were highly associated with the factor VII, so temporally related. We gave the drug, they had the clot, bang, bang. All right, and about 1% of those were serious, and by serious I mean instantly fatal. Like we gave it, the ST segments changed, the heart stopped, they died. Or we gave it, they infarcted half their brain, they died. That's happened to me 1% of the time when we've given it. All right, and that's about the trade-off. On the other hand, 90% of the people stop bleeding, so somewhere in there is a risk-benefit balance. You don't want factor VII casually, but in the right situation, it's an important tool. Here's what we did with PJ. He needed the jump start. This is the jump start to get his coagulation system going, so concentrated factors, cryoprecipitate, which is essentially fibrinogen, platelets, which are inherently concentrated, a blast of factor VII. You can see the Amicar up there. We do read the literature. This is an antifibrinolytic agent, so something you give to preserve clots over the long haul. Comes out of the cardiac literature originally, works, we think, in trauma patients, but it's very hard to gather the data. Big study recently published in The Lancet called CRASH-2, which took a look at tranexamic acid, which is a related compound, internationally, found a survival benefit from giving it early to trauma patients. I don't entirely believe the statistics or the methodology in that study, but it was 20,000 patients, and it was a survival benefit. And this is a drug that, as far as we know, has no side effects. So we give it. This is what we have in our trauma center that's similar. An hour later, PJ had stopped bleeding quite gratifyingly, and you can see all the numbers are back in the box. And here's his clinical outcome. 24 hours, he was awake, alert, responsive. 3 days, he was off the ventilator, extubated. The ICU nurses were very concerned about him initially because he was kind of goofy, and they thought maybe we'd knock something off in this. But then his parents came in and assured us, oh no, that's normal. Got his abdomen closed at 5 days, went out to rehab, home from rehab in slightly more than 2 weeks from the whole event. Returned to the trauma center 6 months later. We saw him again to get his abdominal hernia reconstructed. He was at that point totally normal for a trauma patient. He was still a knucklehead, and we'll probably see him again. But this was a gratifying case. He pretty much encapsulates everything I know about hemorrhagic shock and how to save people's lives, and I will leave you with the same confidence that these people have. Thank you very much.